Well, I'm going to talk to you about pediatric fractures. For some reason, I have done so many of these at our center for years and years and years, but they're relatively rare. And most of these will be cervical, with maybe a few if we get to the lumbar ones, because we kind of covered a little bit of the chance fractures and seatbelt fractures earlier. We're going to kind of look at the literature, look at biomechanical features, cervical injuries, a few thorax, and a little summary. Um, Pediatric cervical fractures, these are the kind of things that I've seen through the years, and they can be really, really catastrophic, particularly the younger children, less than 8 or 10. The really occipital C1, C2 upper level injuries are what you see with them because their heads are big and their ligaments are flexible. And when they hit, they literally pull their head off. And these are usually unsurvivable injuries. And there's just a couple examples of different ones I've had. And again, we kind of went through a little bit of the bony chance and the seat belts for younger patient injuries and covered a lot of that earlier, but we'll go through a few of those if we get a time. Kids have a little bit of unique mechanism of injuries. They tend to be more sports injuries or falls or high-speed motor accidents, unrestrained or restrained. A lot of child trauma can cause upper injuries. And it's because the ligaments are different in children. The facets are flatter. They tend to dislocate more. Their anatomy is quite different up until they get to be about 12 or 13. And then they pretty much have a mature spine by then. And you'll see the adult subaxial injuries more commonly, such as fracture dislocations in the lower area. The most important thing you want to realize is treatment of these is a little bit different because they're so much smaller and scaled down. So it really helps if you do. We see a lot of low back pain, children's tumors, and also degenerative changes, which is not uncommon. And so we have a pretty good experience and comfortableness for these. So most of the things you're going to see are like a little child like this that's 3 weeks status post or motor vehicle accident. I still see this girl once in a while. She's got just a classic torticollis or wry neck. She's the C1, C2 facets, they rotate very easily and tear the capsules and they get locked in position. And you can see there's a little bit of signal up around the C1, C2 axis where she's jumped her facets a little bit. And so we just basically put her in traction, put her on some muscle relaxers. And you can see after a couple of days, she pops right back into position. And now her motion is normal. And I actually still kind of see her years later just to make sure nothing else happens and everything. So these are the usual kind of low energy injuries you'll see. So when you look at the incidence, boys are greater than girls. Most of the things are from MVAs usually, and it's a little bit higher depending on, there's a little racial preferences in some of these injuries. And it's about 2 per 100,000 in children. And this has been updated. Most of these are going to be seatbelt injuries or injuries suffered in MVAs. But you see a fair amount of firearm injuries and sports injuries and falls from height in these children also, as Vitality has pointed out. There's a lot of articles about subaxial injuries. Generally, these occur from 9 to 16. They tend to be more of an adult pattern. Quite honestly, less than 8 will usually have an occiput C1, C2 type injury. And another article by Platzer, not a lot really written on children's because it's hard to follow these kids. Younger children have high cervical injuries, confirms that older children have low cervical injuries. In this particular study, there was up to a 66% rate of neurological injury. I have not found that to be the case. Most of the time, there was minimal chance of neurological injury. They're minor injuries. Another article by McCall, who's a neurosurgeon, he also pointed out that most of these can be treated conservatively. A lot of times, he really kind of wrote the article about halo treatment of adding more pins, 8 pins, and he recommended halo vests. We tend to treat a lot more kids with Minerva type brace because bracing has advanced somewhat. An article by Babu looked at that it's hopeful, and we do believe, at least intuitively, that these children will have a higher chance of neurological recovery because they heal so much better, particularly the children that are in the earlier age groups, less than 10. But we don't really have any prospective studies to confirm that because, again, this is such a difficult patient population to follow. And these injuries are relatively rare, fortunately. But we do feel that that's why we're pretty aggressive in treating these children. Another article by Hasley said that you should be very careful in that you can miss an upper cervical injury, particularly in these children when they have a depressed Glasgow coma scale. And so you really have to carefully examine them to make sure there's not some sort of subtle injury on these children. And as he also found that most of these are admitted for other reasons, the fractures are found incidentally, and 70% of the cervical injuries could be treated with a collar. So a pretty good prognosis. Kenneth Chin also pointed out that they're again particularly difficult to identify with polytrauma. You may not even know they're there. That's why all these children should be screened with the severe polytrauma from basically occiput to sacrum to make sure you're not missing any fractures. And if necessary, proceed with a sedated MRI to find something more subtle. The epidemiology, most of these, again, according to Sal, can be treated non-surgically. Out of his series that he reviewed of 546 patients, non-operative treatment was indicated in 96% of them. So you're not often going to have to take these patients to surgery. You can treat some relatively serious injuries with conservative care. Here's another article that basically said that the spinal cord injury rates have fallen over the last couple of decades. They continue to fall, mainly because of the safety measures we've taken with car seats and seat belts and shoulder belts and things along this line. So a lot of less injuries also with sports injuries too. So this is what Platt found more recently. And Shin also looked at this and found that, again, looked through a database and basically found that mortality factors were relatively low, that the cost was low because the children weren't hospitalized that long. And again, there was a very low mortality rate in kids with cervical injuries. Remember, this is very important, and I'll show you a couple of cases that physicians should maintain a high level of suspicion when they find multiple injuries without a major polytrauma, such as an auto wreck or a fall, and be suspicious of a possible child abuse situation that you may need to address. So this is another thing, certainly in my children's hospital, that we are constantly paying attention to. So when you look at a summary of the literature, there's small numbers, short follow-ups, a lot of databases. There's no real established trauma protocols, although we apply generally adult protocols and instrumentation now down to children age 3 or 4. We can successfully use pedicle screws or wiring techniques. And so there's an absolute need for prospective studies, but they're incredibly difficult. And most of the evidence is somewhat presumptive level 4 or level 5 professional experience, which is kind of what you're getting now. So there's a lot of mechanisms of injury, including gunshot wounds that you'll see in these patients. Generally, what happens is both for seatbelt injuries and chance injuries in older children, and particularly neck injuries, you basically have an injury where you get a hyperflexion either of the neck or the spine, depending on whether they have the lap belt on or not. And of course, there's a lot of sports injuries and rollovers, and of course, gunshot wounds that we'll talk about. The other thing that's really improved as far as why we don't see as many neurological injuries we used to is we have specialized pediatric boards and collars in our ambulances in Kentucky now. And we generally don't use tongue traction in children. And they go to we're a level 1 pediatric trauma center. And so they really get the other polytrauma treated and stabilized. And then, of course, we're called if we need to do something quickly as far as stabilizing the spine. So much better ER training and pre-hospitalization transportation by our ER services. But it still happens. One of the biggest things we see is this, where a child's put on an adult transport or has a pillow put under their head. And here's one just recently that most of the pediatrics will have a cutout to their head and axis remains in line. And this one actually came in and was displaced with a C1, C2 transverse ligament rupture. So the bottom line is we've had good improvement of our EMS immobilization. We are better decompressing and stabilizing the spine. We have some pharmacological things that have been tried, less things successfully, obviously. And of course, hypothermia can be helpful, but difficult to apply as far as these kind of injuries. So here's just a few things about why children are different. The ligaments have 4 times more stretch than the spinal cord, and this can result in a SCIWORA injury. And the conus also, remember, in a young child may be down at L3 or L4. So when you operate on them, you have to be very careful. Or a burst injury, for example, how rare they are, a chance injury can result in a significant injury in the younger children, 3 and 4 years old. The other thing to remember, and these are all kind of board questions for the guys, if the children are less than 10 years old, they have virtually a 100% chance of developing some sort of paralytic scoliosis. If they're a quadriplegic or even paraplegic, they may develop some deformity. Also remember that the fractures, which is why you don't see burst fractures, tend to get distributed over multiple levels rather than focused at just one level like you see in adult. Finally, remember, you also can have growth plate injuries and fractures through the growth plate, and we'll show you some examples of those that also may be a little bit more difficult to treat. The other thing remember that the infant spinal cord can stretch almost 2 inches, okay, But the problem with some of these injuries, but in reality, you only can have about a half inch of stretch of the spinal cord before you suffer an injury. So just the major fact that they have such elastic ligaments and flatter facet joints, when you get these SCIWORA type injuries that we'll talk about, you can dislocate the spine or stretch the ligaments or tear them, not even see them on X-ray, on plain X-rays, and get a neurological injury. And that can be very frustrating. But if a child doesn't move his upper extremities, they either have a brachial plexus problem or they've already stretched their spinal cord. So pay attention to these kind of fine details when these kids come in. So treatment considerations. Surgical treatment for fractures of the cervical spine is indicated if there's impending neurological injury or loss of biomechanical stability. It's a very simple concept like we talked about earlier today, and I'm sure has been discussed by many of these people. And it's no different in children when you treat these kids. If they've got a neurological injury, you have to find out why they do. And but it's difficult because when you look at these initial screening X-rays, which is why we end up doing even CAT scans on these younger children, despite the radiation risk, the neurological injury far outweighs the risk of possible potentials from that as far as long-term sequelae. But they can have pseudosubluxation 20% of the time, wedging, left lordosis, increased prevertebral space, and a lot of different things that will really fool you when you look at the X-ray. So be aware of when the odontoid fuses to C2 at 6 years old, and you can have 2 to 3 millimeters of subluxation, and you can also have the ring apophyses there that may confuse the X-ray picture. And also, the C1 and C2 are particularly difficult till you get to be 5 or 6 years old because they have 3 different growth plates in C1 and 4 different growth plates in C2. So when we look at these things, you can see here there's a lot of different things. You've got some irregularities at the end plate. And here's a person involved in a rollover, and this was thought to be a fracture here on the right, but in fact it turned out just to be a vascular channel. And here's an example of pseudosubluxation, vertebral wedging, and of course the infamous ossodontotium that will confuse and make you think there may be an acute fracture. So you need to have a good pediatric radiologist that's used to reading those, and if you're going to do pediatrics, be a little bit attuned to some of these normal anatomical variants that you can see. So SCIWORA, spinal cord injury without radiographic abnormality. This is less frequently diagnosed now because we have MRIs. And so a lot of the literature and databases go back, 20, 30, 40 years when not a lot of these kids, they got CAT scans, but they didn't get MRIs until more recently over the last decade. But usually if you look underneath, you can find something with an MRI. The problem with these injuries is they can be quite severe. And the bottom line is if you have a normal cord, obviously, according to Pang, you have complete recovery. But if you have edema, you get most of the time 75% improvement, minor hemorrhage 40. If there's major hemorrhage or complete transection, obviously the results of treating these with bracing and whatnot or any surgical treatment is probably quite poor, and they have poor outcomes. So you can see that less than 9, okay, a severe injury is much more common than over 10 because of the stability of the cervical spine increases as you get older, and you see fracture patterns that are more amenable to treatment and surgery. So young children tend to have much more worse neurological injuries because of their mobility of their spine, and that's a real issue. So how do you get to SCIWORA? It's very simple. Your ligaments are more flexible. You can actually move your neck within normal range of motions enough if they all move simultaneously to stretch the spinal cord, as I mentioned earlier. And what you'll get is a situation where you pivot around a point, you stretch the spine, and it snaps back. You pull the spinal cord and actually get damage to it, and you get secondary swelling and the penumbra of spinal cord injury, and they end up. And here's exactly what it looks like. It'll usually occur toward the cervical thoracic junction, and you can actually see where the fibers and the spinal cord has been disrupted and damaged in that area. Now, how do you treat them? Most of the time they're treated in a brace. One study, a large study, shows that a brace offers no benefit. Another study showed that a brace does benefit the patient. So it's really a flip of a coin, in my opinion. We do tend to brace them. I probably recommend that because often they may have some other polytrauma issues and you just want their neck to be held stable. If they do have ligamentous injury, you ought to provide some sort of stability so that you don't stress their spinal cord. So here's kind of what we tend to treat conservatively: Jefferson fractures, odontotiums, and Hangman's fractures. We always tend to treat these with just bracing. And when they do need instrumentation, there are a couple of different articles that have been written by several people, and since then, and you can use traditional things that we use. We often, because of the size of the pedicles and lamina, we will use sublaminar wires. We also can use interspinous wires if they're not broken off. And you have to do more levels sometimes than you would like to because things will have multi-level fractures of the posterior elements. You also can do what we call a compere or dura, where you put a bone graft on there to reconstruct the area and pass a couple of pins across it and fuse it. That's another option. And of course, you also, if it's a dislocation where you can pop the facets back in older children over 12, you can do a traditional anterior body fusion. Most of the time now, if the child's over 4 years old, the pedicle screws that are currently available commercially will almost always fit in the lateral mass. You may have to use 8 or 10 millimeter screws, but you can get a good posterior fixation with traditional posterior instrumentation using laminar screws, pedicle screws, and rods and things along that line. So some cases just are not repairable, like you see here. These kids are basically brought in intubated, and they're basically locked in syndrome. They've ruptured their vertebral arteries, and they're most likely going to expire. And so when you look at the CAT scans, they're pretty amazing of what you can see about the amount of damage. Again, because they basically have a bowling ball on top of a articulating gimbal, and that widely distracts when they strike something. So here's some examples of some things we can treat. Here's a 10-month-old male that basically doesn't move his upper extremities. It's almost like he's an upside down paraplegic, so he's like got a central cord type syndrome, and he doesn't pick up his pacifier. And you can see there's a little bit of dislocation and gapping between C1 and C2, and otherwise everything looks pretty normal. With flexion extension that was done on him, which probably might not have been the best thing they've done in the emergency room, but he turned out to basically have this situation here that you see real quickly. You'll see on the left that he's got bruising centrally at C5, 6 of his cord. Also, you can see through the axial views. So he suffered child abuse. And he got smacked around because he had other associated bruises and contusions about his body. And so we just put him in a collar, and he did quite well. Now here's a two-year-old that comes in that was unrestrained, unconscious. And if you look at the top, up in the area through here, you can see a massive edema and swelling and blood all the way up and down the prevertebral area and around the C1-2 axis. This patient has basically transected their cord, and they're unconscious, and they're basically not going to pull out of that. They're going to expire because this is something that just generally can't be fixed. They'll just simply stop breathing and be respirator dependent forever. Although I'll show you some examples where they were successfully intubated. Something on the milder form. This is a child that jumped off a bunk bed and landed right on top of their head, according to the mother, and suffered a compression fracture. Now, you don't see these that often. Something you would just treat in a brace. No problem. They do well. Now, here's a 4-year-old unrestrained female that basically comes in with this fracture. You remember how I told you the epiphyseal fractures? Well, that's what this is right here. And you see your odontoid is basically popped right off the top of C2. Now, how are you going to treat this? This would be pretty tough to treat surgically, right? Well, here's a close-up right through the growth center. And so we're just going to put the child in traction and pull it back with a little bit of extension. It pops right back on. You can see on the MRI it lines up. You don't have to hold these long. These are going to stick down within a couple of weeks. So a little bit of traction for a week or two, and basically it sticks itself down. And we're going to put it in a halo and treat it for 3 months or so. And the child went ahead and healed well. Keep in mind when you put halos in children, generally you want to have them over 5 years old, and you often need to use 6 pins or 8 pins, depending, to get good fixation with minimal torque, usually 4 to 6 pounds, and that will work relatively well on them. You do need to be aware that you can have some rather serious problems. The kids' skulls are a little bit flexible, and you can perforate them and get actual perforation of the tables and get a CSF leak or some injury to the brain tissue. So remember, the high complication rate, you have to really be diligent and keep the pin sites clean. So here's a 5-year-old female that comes in with an unusual kind of injury because it's really subaxial, and you can see she's basically had a hyperflexion injury and an MVA, and somehow got enough flexion right at the cervical thoracic junction to tear the interspinous ligaments and all the facet joints as you see here. But she also has 7 compression fractures. So somehow she compressed her spine at the same time she hyperflexed it. And you can see there's soft tissue swelling. There's splitting of the lamina in the back, as you see here. And she actually has a cervical chance injury, along with some comminution of the vertebrae up front, like you see right here, which is really, really rare. But you will see this. And you can kind of see it also on the CT scan here, where the posterior spinous process is split right in two. Again, she's well reduced overall, and they heal so quickly. We just put her in a Minerva brace, or sometimes a TLSO with a SOMI extension, as you see here, and she completely recovered with this and healed it up and did well after 12 weeks, and we didn't have to do anything surgically. Now here's a 4-year-old that comes in, was seen in an outside hospital, was okay, supposedly, was put in a collar and shows up at our facility. After it was noted 2 or 3 hours later, she couldn't move anything. And so they ship her to us, and sure enough, she was definitely a paraplegic. And so when we get an MRI, here she has a classic SCIWORA injury, even in this day and age. And this is somebody we would just brace, and hopefully she had some recovery, but she still remained a high density Asia B or C, if I remember correctly. So you can see the classic injury there, and she was braced and basically was watched for neuromuscular scoliosis. Now here's a 5-year-old male that arrived intubated. He was relatively obese, and he had a fracture that you can barely see here around the area, and he wasn't very obese, rather. And we really had a hard time trying to figure out what was going on with this kid. So we went and sedated him, and we did an MRI. And now you can see all up around the top here, all this fluid, prevertebral. Look for these soft tissue signs because you may not see much with the bone. All around the odontoid here. And you can also see fluid within the joints, and I'll kind of go through here. And you can see what they were with a couple of serial things. And this is a kid that we went ahead because he had so many other injuries, treated him in a Minerva brace, and I personally changed this brace with my PA. About every 3-4 days, we'd go over and change those pads so he wouldn't get any skin problems and everything. And you can see here that he's actually, when we finally got him in the brace, you can see there's a little gapping between the occiput and C1. And you can see now with your MRI how the saddle joint, C1, C2, the base of the skull, and the top of C1, there's actually fluid in that area from the injury. And this pretty much sealed the diagnosis. So we decided not to operate on this kid because we didn't want to completely destroy any future of motion of his head. And he was slightly neurologically involved with some generalized weakness of his legs, but that rapidly cleared. It was just from a minor stretch of the cord due to his head being somewhat of a projectile. But you can see the fluid within the joints and a little bit of gapping on the CT scan, as you see here. Pretty clear. So we're going to go ahead and follow this, and with time, he basically heals us up. And this is the healing potential of kids less than 6 to 8 years old. And there's a couple of articles that talk about this, that they will actually reconstitute the capsules around these joints, and you can get away without fusing them most of the time. So here's his flexion extension views, and here he is ready to go home 3 months later with just a soft collar. And I actually still see this young lad, and he completely recovered. So here's a 17-year-old male, ATV accident. We see these all the time. Now he's an adult pattern. You treat these kids once they get over 12, just like an adult. And you can see he's got an odontoid slice injury going through, kind of at an angle, probably maybe in a non-vascular area if you were older. But again, remember, there's much more blood supply and there's much better healing in these children than what we see traditionally with adults. So we went ahead, and since he had no spinal cord involvement, we went ahead and put him in a collar, and he also went and healed very well. So those are kind of the things you can treat and why children are a little bit different than adults. Now, that's not always true because a lot of times you're going to see patients that come in and do need surgery. Okay, so here's a male that came in with a displaced odontoid fracture. He's older, less likely to heal, and he basically had a posterior wire procedure and a magneral screw that went across the joints up into from C2 to C3 to hold in position, and he did pretty well. These are kind of difficult to do, particularly when we didn't have guidance. They're easier now, but I think these have been really supplanted, at least in our practice, by C1 lateral mass and C2 pedicle screws, so we don't do these that often anymore. Now here's a 17-year-old. You see we're shifting into an older age group. Morbidly obese comes in, basically had a significant, lot of injuries. We're going to have to stabilize her as quick as possible, and she's got significant weakness in her arms. And so when we get an x-ray, look what we see here. We've actually got kind of a dislocation distraction injury of C2 on C3, very difficult. And it's broken. It actually goes up into C2 almost like a hangman's fracture, and it's displaced, it's unstable. So we're going to have to fix this in this age kid and stabilize her. And the vertebral arteries, you should always do an arteriogram on these older patients because there's a pretty good chance that they may have an avulsion, but hers seem to be relatively intact. And when you really get an MRI, now you can see that she's actually broken through a residual epiphysis probably and broken or snapped her end plate off at C1 too. So here's a close-up of it, fluid in the joint, why you really need to diagnostically work these patients up. We tried to reduce it with traction, but it wasn't such a big success for us. And so when we put her in traction on the table, look what happened. Now, I just want to let you know this is a come to Jesus moment when you see this. And we're just like, well, what are we going to do now? Well, it was real simple. We released the traction and we put her in a Mayfield. We didn't do anything else. And she comes right down into position. And this is somebody that we're going to have to put instrumentation in and surgically bring her back into position with just postural reduction and also clamping and place in our screws. You can see she's kind of jumped here. We're going to bring her facets back and realign her spine. And we can do intraoperative CT scanning now, which helped us. And we're going to put in lateral mass screws and pedicle screws and nicely reduce her. And she did well and completely recovered with a relatively difficult injury. Now, here's a 16-year-old male with a 15-minute episode of paraplegia. So we're thinking, well, he's got some sort of SCIWORA. Well, but if you look carefully, you need to be aware that kids can have congenital cervical stenosis. And that's what this young lad had. And he ruptured a little bit of disc there, as you can see, in his canal, 6 millimeters. And he's playing football and everything. He went back and actually played, and he's got a spinal cord contusion with the bilateral kind of little punctate owl's eye, we call them. And so we're just going to go up and we're going to make his canal bigger. He recovers completely after this. And so we just do an ACDF at that level where we had isolated congenital stenosis for some reason. Now, I hate wrestling, okay? Wrestling is a very high risk kind of activity sports-wise because the idea is to pick them up and pile drive them down, and a lot of times they'll hit their head. And they suffer these terrible injuries. You can see here between 4 or 5, you can see how the posterior longicular ligament's been ripped off through some subluxation. He recovered his quadriparesis, and by the time we saw him, he just had some tingling and numbness and some just mild diffuse weakness in his upper and lower extremities. So we get an MRI, and you can see he's definitely got a torn annulus there, maybe a little bit of disc material back there. And you see his canal is actually reconstituted pretty well. So we went ahead and did an anterior discectomy and stabilized him, and he got completely better without any sequelae. Here's a 17-year-old male in a ski accident, okay, now with severe neck pain. Okay, we don't really see much, or do you? When you start looking at that vertebrae, it's not really a fracture. You need to be aware of underlying pathology may cause a pathological fracture, or what we would think would be an acute injury fracture because the bone's weakened. And this young gentleman turned out to basically have an aneurysmal bone cyst that we just had to go in and curette and did an anterior body fusion on. Now here's another example of a 10-year-old male, which is the classic pool accident that you'll see, where he jumped in, hit his head, had numbness and tingling, and then he went and played a game of football, amazingly enough. But he continued to have some more numbness and tingling and neck pain following this over the next couple of days. And so he came in, and by the time we saw him, you can see that he's got a relatively severe compression fracture and has ripped his ligaments, including the posterior ligamentous complex. And basically, this really would constitute a 3-column injury has been involved with this. So he's unstable in the neck, and he was just simply fused and wired because he's 10 and placed in a Minerva type or SOMI type brace, and he just went ahead and healed this up fine. Now in Kentucky, we have this unique sport called drag racing, pediatric drag racing, kids drag racing, and they get in these drag racers and go off the line just like the Nationals in Ohio, and just go as fast as they can. Well, this 8-year-old female took off real fast, and she was ahead, but she missed the brake and hit the wall, the retaining wall at the end, and this is what she had. And they managed to intubate her because she still had some respirations and get her to the hospital, where now we're faced with having to fix her. And you can see she has a occiput C1 dislocation. So we're immediately going to put her in a gentle traction to reduce her, which was effective. But now we're going to have to stabilize this. And she has some very minor upper extremity function left. And you can see all the massive amount of edema here. So this is somebody that we're going to have to just do a formal occiput to C2 fusion on because she's so terribly ripped apart, and she actually survived this and actually ended up being about an Asia B to C, where she did have some anterior function. Football, a big thing that we see injuries. Just another example comes into the emergency room after basically landing awkwardly and having loss of sensation. He had upper and lower tingling and numbness and weakness, particularly of his upper extremities. And, football, look at McGinty's article. There's with improved not allowing them to spear and trying to be a little bit conscious of this and the better helmets and everything, we don't see these as often. but we still see them, and they can be acute, devastating neurological injuries in American tackle football in the high school population. And this is what we saw. We had a fracture dislocation. You can see it very nicely on the CT scan, and you can see bruising of the spinal cord, which is why he has his neurological symptoms. This is a unstable injury that needs to be addressed and fixed as soon as possible. It's a 3-column. You can see all the posterior ligaments are also torn. And we did do an arteriogram on him, which you always should do, and you can see one of his vertebral arteries is knocked out. Fortunately, it wasn't the dominant one, and you can see it on a couple of these views. And so he's reduced with a little bit of traction, which is very important. It looks good on the x-rays, and we take him to surgery, and we're going to go ahead and actually stabilize him, as you see here, with posterior instrumentation. We repeated the arteriogram, and the vessel did not reconstitute, but he was okay. And he got better postoperatively rather dramatically. And here's his final construct where we've got him completely, we fused long on him, and he almost completely recovered and wanted to go back to playing football, which naturally we did not let him do. Now, Kentucky is the land of tornadoes. And about 3-4 years ago, we had a major one come through Western Kentucky, as you see here. This was an F4, and it went through Madisonville and basically flattened the city. These are actual pictures with Governor Beshear talking about it. And we had several patients come in, and we had one girl and her brother both in a trailer home that got tossed probably about 100 feet out of the trailer and landed. You can see there's a lot of funny things going on here. You've got C3 on top of C4. And when we looked at this in more detail, you can see that she had a compression injury with a flexion injury. It involves 3 different vertebrae. And then you also have one down at C7. So what are you going to do with it? You're going to fuse everything in a young girl like this? So we decided to go ahead and just try to do something more selective. And you can see that she basically has a cord contusion on both these views here on the MRI. So we went in and we did just a selective fusion of 3 vertebrae from essentially 3 to 4 and 5, and try to ignore the more minor fractures and put her in a brace, quite a stylostomy brace, neck brace, and she completely recovered and everything. So how are we doing as far as time, Jen? Is that about 30 minutes?
Yeah, how much more do you need?
10. It was a 40-minute lecture.
Go for it.
So I'll just go through a few of the lumbar things. There's not a lot written about lumbar fractures, and basically Dogan, Van Have, and Santiago have written the articles. The fractures are unique to chance, and in the middle age, usually 18-year-olds, and the seatbelt injuries like we talked about this morning. There is real no classification of it, although the TLIX works reasonably well, but not great. So we treat these as adults generally. And you're going to see these almost always. As I said earlier this morning, the seatbelt injuries are in 7, 8-year-olds down to age 3. After the age of 12, they tend to be more of a chance type injury or just a usual adult fracture dislocation or burst injury. But Savage, this is where we looked at the TLIX, and he pretty much said that we determined there was good reliability. Here's basically a couple of fractures. This is by a guy named Kinepulu, who said that most of these patients, as with the cervical spines, can be treated conservatively. Here's another article out of the Canadian Spine Journal that polytrauma should also be examined for cervical and lumbar injury. We've talked about that, but they looked at a lot of lumbar injuries. There's a lot of minor fractures around the lumbar spine, like TP fractures or posterior spinous process fractures or minor compression fractures. Those tend to almost always heal directly without any surgical intervention and just bracing. But again, these are the 2 fracture patterns that you're going to see mostly in children, the seatbelt and basically the posterior distraction, that it will be either chance injuries or frank fracture dislocations. And these are just a few of the different ones we've had through the years, of the more dramatic ones where you can really, you can see the one that has the gas in it. That's actually a loop of bowel that's stuck in between there. So they can be quite devastating. Like here's a 14-year-old that fell from a tree, and he's got a classic burst injury. He's got an adult pattern. And he basically comes in and he's Asia E, and he has lower extremity, no numbness or tingling, something that you can just put in a brace. Okay, now here's another interesting one, 18, which is a lower lumbar fracture, which is an entirely different subject. But he comes in with this really bad burst fracture, okay, and we just put him in a brace, and he also got better. And here's another 18-year-old with a low lumbar fracture, okay, and he looks like this with a little bit of L5 radiculopathy, believe it or not. And these almost always will get better with a brace, and that's what you probably ought to try first. Now here's one we just saw actually 2 weeks ago that comes in, and you can see how terrible this is. And we get called in the OR. to see this patient, and she has a avulsed SMA artery, and she's bleeding everywhere. And they're trying to clamp off, and we go in and say, well, yeah, we'll try to fix this when you guys get done. But she actually ended up expiring. And so sometimes you just can't save these patients that have these kind of severe seatbelt injuries. They'll actually just completely expire on the table. So here's another patient that comes in. Basically, when you look at it, you can see that you don't see much to begin with, but then you start looking and you see there's a hematoma within the spinal cord here, and the patient has a very high level injury, is completely paraplegic. And even though most everything's intact, other than this little bit of disruption you see down here, that was very difficult to see between 1 and 2, the patient actually dislocated, came back, and avulsed their spinal cord. And when you see situations like that, you're probably going to, we went ahead and fused it, and we could actually see how terrible it was torn. Look at this, where all the muscle is torn. There's a CSF coming out. Things are just torn into. You don't need to repair those CSFs. They just have a giant blood patch in there. And so we did this long stabilization because of the instability. And here's the brother out of the tornado that I showed you. He got tossed 100 feet into a river, and he's got a very severe 3-column fracture dislocation with a severe burst injury, and all the ligaments are torn in the back, 3-column injury, and the canal is actually remarkably open. And he was mainly neurologically intact. He was maybe a high grade Asia D, went to Asia E pretty quickly, and you can see that when we stand him up in a brace, things don't go so well. So this is a guy that we took to surgery and reconstituted him. And we went in there, you can see how everything is literally torn in two. And he has a degloving injury. When you have a fracture in the lumbar spine and you have degloving injury, it's a danger sign. There's a pretty good chance they've got a very high grade injury. So he warranted maximum stabilization, as you see here. And he got much better and completely recovered. Both him and his sister are actually Asia E now and everything. And we follow these people long term. Now, here's a 17-year-old male with a fracture dislocation at L5S1 with comminution of the posterior elements and tearing of the disc. These are you'll see these occur anywhere in the lumbar spine. And you can see there's a large mass in there. Okay, what in the heck is that? And he had real severe weakness and numbness in his legs, almost like a cauda equina syndrome. He's fractured both pedicles and jumped them and has a traumatic spondylolisthesis. So we're going to go in there and reduce this, and it was really unstable. And this is the disc that we pulled out that was completely ruptured out of the 5-1 disc space. It was torn off both ends. And when you see that, that's what you'll see in trauma. The disc will actually get ripped off of both end plates, and there'll be a huge herniation. And so we went ahead and did big time stabilization on him. We did stack screws or actually here we did S2 and iliac screws. And here's what he looks like 2 months later. We say, touch your toes. And he's completely recovered. So you can see he's a tough guy. But look at this. He just does everything we want him to do. Completely recovered from this. So one more case. Here's a 9-year-old female that you can see has a classic kind of distraction injury that you'll be able to, seatbelt injury, distraction injury. And it's really more of a chance injury. Always look for the seatbelt stripe, as you see here. And you go in and everything's ripped in two, including the muscle fascia, the paraspinal muscles. And again, maximally, you want to fuse long on these because at this level, it doesn't much matter. And she did yet. So I thought that was the last one. But here's just another one. This patient was hit just recently, was hit by a car and has a massive injury here. And this is the one trick I want to show you is you can see she's got a 3 chance type injury with a burst component, 3-column. Okay, she's neurologically, emotionally intact. She has multi-trauma with 2 broken tibias, a broken femur, broken forearm, and humerus. So we were asked to stabilize her as quick as we can. Well, I don't want to go down to L5 on her and do 2 above, 2 below. And 4 mostly was intact. So we went in and basically, here's the MRI that shows you how terrible everything is ripped apart. And 3-column. She's got an epidural hematoma that we took out. And we took her to surgery, and you can see everything's ripped in two. What you'll see when you see this, and we're putting it right between the rip between the posterior lamina there that was split. And so we reduced her very nicely. So what we do on these is we'll take them in and we'll instrument them. We did guide on her, and we'll use bilateral sublaminar hooks on the bottom level, and that'll save you a level of fusion. And so this is what it looks like. We were able to stop at 4 instead of 5, and she completely healed and has done well. So we'll stop there as far as the lumbars. There's a lot of other things, but that we won't go into. So do we have any questions at all? That's 40 minutes worth of pediatric
Fantastic.
fractures.
So let's get to outstanding, first of all. Thank you. Comprehensive and my goodness, that's a collection of serious injuries. I have a very simple question about workup. So MRIs, specifically C-spine MRIs in young kids, just consider the following. This is actually a real life story. Good friends of ours, 10-year-old daughter, ski team, falls, witness 35 feet out of a lift onto packed snow, is kind of bedazzled out of it, then comes to it, screams and shouts and is inconsolable. Not scratch a 10, about 8 years old, inconsolable. And she gets taken to a local hospital. She has no neurology. And they get a C-spine x-ray, which shows the infamous C3-4 subluxation. So the treating ER doctor, without much further thought, sends the kids to the MRI scanner. And I got called in because she basically had turned anoxic in the MRI scanner. There was sedation done because she was screaming in the MRI scanner. She couldn't be calmed down, so they gave her a healthy dose of vitamin V. And she basically then didn't breathe right anymore. So MRIs in younger kids are a problem. How, when, where should they be gotten? Do we really need them? Do we always need to intubate them if we want, or have a very controlled sedation? So talk a little bit about MRI scans in younger kids, especially C-spine.
I think that 95%, and you can correct me, of the time you can tell on you're going to get fooled a few times. But 95% of the ones that are going to need surgery, you can tell on a CAT scan and plain X-rays. Okay, and if they're subluxed and you see fracturing of the facets or the posterior spinous process, or splaying or subluxation more than 2 millimeters, and particularly if they're over 6 or 8 years old, you should be able to know if they're unstable. And we always have the ability to do traction and bracing, which will almost certainly stabilize these patients until we can assess them further before we start ordering an MRI. An MRI is reserved, I think, for when you don't know really what's going on and there's no other conceivable methodology you can do to diagnose if you suspect something like a SCIWORA injury. And SCIWORAs will generally look quite stable and probably are stable in a way. And those are the people that you have time to go ahead and do an MRI. So I don't usually, most of 90% of the patients I'm taking to surgery, I already know they're unstable. And you've got this thing called your finger, particularly with thoracolumbar injuries, not so much cervical, but they will have, if they're conscious, terrible, terrible pain in where the ligaments have been torn. And so you've got a lot of different things you can do, tricks that you don't need to MRI all these people. The problem I have mostly is the high grade Glasgow score patients, that basically are comatose. And those are the ones that you really need to automatically keep in the collar, put them in just head weight traction, and just let them get stabilized, and then assess them and everything. As long as their spine's lined up, you're probably okay. So I'm not a big MRIer unless I'm really stumped by what's going on with their spinal cord and neurological function.
So I also liked your thought about, thank you for that answer. We can get out of the talk mode, maybe, Ben, so Dr. Dimar appears big on our screen. Thank you. So the key other thing I wanted to bring up is that a dividing time of non-surgical care for clearly ligamentous injuries and the more adult acting children. So that periosteal remodeling time, I'm still not sure when that is. Tony Avellino and I published in The Very Young on the shaken child syndrome with non-operative treatment for under 2-year-olds with child abuse. And it was amazing to see how the periosteum would actually form an endosteal ossification response and heal. But I'm not sure where the age time cutoff is and how to kind of look at that, and how long to keep these kids at bed rest. I mean, we basically said at the time 6 weeks and then start setting them up, but that was just measuring by thumb. And we don't see that. I don't see it in my practice anymore. But what's the time cutoff when we can kind of, or after which we can't count on the periosteal ossification taking place?
Well, I think less chronologically and more physiologically. So there's a lot of, I think girls in particular that are 12 years old, that are 12 to 14 are probably skeletal mature, and they're almost certainly not going to heal ligamentous injuries, in my opinion. And I generally, if I'm not sure, I will examine them. If they have a lot of pain there, then I'll put them in a collar. And if they're not subluxed, I'll follow them with 2 week plain old X-rays, and they'll sublux once their spasm goes down. I think kids less than 8, and certainly less than 6, as I showed you a couple of cases there, you can definitely brace them. And I don't keep them at bed rest. I keep them with guarded activity, like sitting up in a. In fact, the upper cervical ones, you kind of want them to have a little weight bearing. You don't want to put them in traction. You want those things to settle down and reduce those saddle joints at C1, 2, and occiput C1 and also C2. And I've just had great success. So I think the 10 to 12 range is where, when you become 12, you really should look at those kids as adult and treat them as such. They probably are not going to heal ligaments, but some boys are relatively physiologically young when they're 12. So I go more about how they physiologically look like too. And so the young patients are remarkable, and they absolutely do heal their ligaments. And the mantra has always been that you don't heal ligamentous injuries except in those younger patients that are less than 8. So that's usually my break off point. And Rome wasn't built in a day. You've got all the time in the world to watch these kids in braces. And if they start to sublux, particularly the older children, you can just go in and do a C1, a C1-2 fusion or a C5-6 fusion. Is that what you all do?
Yeah, no, I don't do these acute pediatric trauma cases anymore, but yeah, I found it very difficult to determine a specific age cutoff. It's there, and I think that there's a lot of overtreatment, overreads on MRI scans, and I totally concur.
Yes.
I look at the patient, I get upright X-rays, lateral.
Sure.
I try to sort out the familial situation just by observation, keeping them in the hospital until we establish with benign social services observational visits included, whether they have a stable footing at home or whether that's not so much the case.
Yes. And the kids have their healing curve is dramatically more than adults. And if they have a stable situation, usually by 6 weeks, they're just not going to hurt much anymore. But
Yeah.
a lot of adults will have chronic pain if they're subluxing or develop radiculopathy. So I just think every kid's the same. And I was amazed at some of the young ones that I've had lately that I put in a Minerva brace and just watched them. And they were all, in the 5, 6, 7 was it? There were 3 of them, and they all healed completely. And with flexion extension views, they were absolutely rock solid between occiput to C3. So you can treat some of these conservatively.
And I loved seeing some of your hooks. Those supplemental upgrowing hooks are fantastic, and cables. We, by the way, have our January, thanks to the generosity of one of our industrial supporters, we have our annual Hooks and Cables Cadaver Lab, because I firmly believe that our fellows in this era of bolt navigation now should still be capable of assessing patients for their suitability for possible supplemental hooks and cables. Very valuable.
They can save your life, save the patient.
Absolutely.
And the biggest thing is that kids' physiology is not adult physiology. I mean, you can, if you're setting a forearm fracture, I mean, it's set in place in 2 to 3 weeks, and you got to re-break it. And the same thing, that the healing capacity in these young, less than 8-year-old, 10-year-old kids is dramatic, and they'll heal those fractures in a brace. And if you can keep them in position, within 3 or 4 weeks, they'll be sticky enough to have pretty solid support in there.
I still want to add to your chance injuries and seatbelt injuries and that entity, that those kids can have a secondary deceralization injury. So the intestines may be intact on initial
Right.
injury. Diagnosing this with the secondary injury survey, especially fixing them short segment, decisively, atraumatically, and then being on the lookout for a secondary abdominal rupture is actually something I'd like to add from personal painful experiences.
Well, I have seen aortic lacerations and where they tear the intima and block it off. I've seen jejunal contusion so severe that it was completely looked like purple mush. I've seen spleens split in two, liver split in two. I have seen just recently that SMA avulsion. I have
Yeah.
actually seen a portion of the small bowel entrapped between the one with the bubble in it, between the displaced seatbelt injury, where it gets sucked in when they were there. We had to go and take that out. And so that's why the general surgeons, the trauma pediatric general surgeons, they're on this. They know and they watch these kids for all these interabdominal injuries that they frequently suffer. And so that's the other half of the team we really didn't talk about, but they're pretty good at doing exactly what you say, following those kids for those things.
That was authoritative. Thank you so much.
Thanks.
We're going to end this.